Good afternoon. I'm going to provide a few housekeeping remarks. During today's presentation, all participants will be in a listen-only mode. Afterward, we will conduct a question and answer session via chat only. If you would like to submit a question or comment to the group, locate the chat button in the toolbar at the bottom of your Zoom window. When you click it, a chat box will appear. You can send a chat to the group or privately to the host by changing the designated recipient in the to box. To do a test, please take a moment now to enter the jurisdiction you represent or work in the chat box. You may send this as a chat to everyone. Please note that today's presentation is being recorded and all audio and video will be available for you to view after the webinar ends. It is now my pleasure to turn it over to Mary Ann Cooney. Mary Ann, please go ahead.
Hey, good afternoon, everyone. My name is Mary Ann Cooney, and I'm the Chief Program Officer of Health Equity at ASTHO. I would like to thank all of you for joining today's Tele-Townhall entitled COVID-19 and Health Equity, Response and Recovery Tele-Townhall. Together, ASTHO, Big Cities, NACCHO, Big Cities Health Coalition, National Association of County and City Health Officials, and the National Association of State Office of Minority Health will discuss how federal, state, and local partners and national organizations can collectively drive an equity-focused recovery strategy. We hope that today will be an interactive learning and sharing session through live polling and a live chat discussion. It's my pleasure now to be able to invite to today's event and look forward to today's presentations. But first, we will hear from Dr. Gail Christopher, the Executive Director of the National Collaborative for Health Equity. Dr. Christopher.
Hello, I am Gail Christopher, and I'm both honored and pleased to have been invited to moderate this very important Tele-Town Hall. The subject, COVID-19 and health equity. I'm not going to list the grave disparities and inequities, racial, age, socioeconomic, that we're experiencing today, because years of working in the field of health equity and racial healing have taught me that the more we repeat these disparities, the more we fuel the unconscious and conscious biases that would, as Ibram Kendi said in his piece recently, that blame the victims. It is time for us to move beyond victim blaming and stereotypes to really look at the deep-rooted causes of persistent health inequities, so that we can develop an agenda and a strategy that produces and sustains health equity. There are many definitions of health equity. I'm partial to the World Health Organization's focus on the absence of avoidable and preventable and remediable differences in health outcomes associated with specific groups. The absence, wouldn't it be wonderful if there was an absence of excess deaths and fatalities associated with COVID-19 among people of color? The speakers today are courageous and innovative and effective, and they will tell you about the many strategies that they are employing to help mitigate the extreme risks that communities of color are facing in this country today. And that's important, it's vital, and we applaud them. We also have to look at the broader context of the vulnerability that communities of color are facing during this pandemic. Those vulnerabilities date back to the beginning of the adherence to the belief in a false hierarchy of human value, to the beginnings of permission to value some people over others, and therefore provide limited access to those things that are necessary for assuring a quality of life. That's a roundabout way of describing racism, and racism has given rise to many other isms that make many groups in our country more vulnerable. Some people use the terms disadvantaged and marginalized. Those terms tend to stick, and so I hesitate to use them, but they are ways of describing how our country has structured and embodied racism. And this pandemic, COVID-19, is exposing that in ways that are shocking and almost too painful to imagine. COVID-19 is giving us an opportunity to actualize, to move from theory to practice, the concept of health in all policies. Because all aspects of our public infrastructure are called into play during these critical times. We are seeing how important health in housing policy is. We are seeing how important health in employment policies and economic policies. We're seeing that the standards of the quality of the air are absolutely vital to maintaining health and well-being. We're also seeing how interconnected and interdependent we are as a society. When one group experiences an excess burden of illness, it burdens the system that we all rely upon. We are seeing how people becoming ill and not being able to work shuts down plants and shuts down places that are vital to our way of life. So this COVID-19 experience should open our eyes, should move us beyond denial of the reality of the harms that have been created by allowing racism to define our way of life in America. We must seize this opportunity, this moment, and move beyond racism to a place where equity is the norm, it is the expectation, and it becomes the reality. I'm excited to hear the powerful work that's being done by the presenters today. They're going into communities, they're knocking on doors, they're making sure the data is available, that it is disaggregated by race and ethnicity. They're designing immediate solutions to the crisis. And we must have these immediate solutions, but we also must use this moment to catapult us into long-term solutions that will indeed remedy and will prevent such outrageous inequities should we face another pandemic. You've heard enough from me to start this panel. I'll have a chance to say a few words at the end. I'd like now to take a moment and introduce our invited speakers.
And this is Mary Ann Cooney again. It is now my pleasure to introduce today's accomplished panelists. For the sake of time, we are only introducing their name and title, but a more detailed bio is on the PowerPoint slide. Mr. Garrett Claybaugh is the director at the Iowa Department of Public Health. Unfortunately, Dr. Caldoun had a last-minute conflict, but we are pleased to have Ms. Brenda Jegede, the Office of Equity and Minority Health Manager at the Michigan Department of Health and Human Services. Ms. Angelina Esparza, until last Friday, served as the Chief Program Officer at the Houston Health Department. She is currently serving as the COVID-19 Senior Regional Advisor for the CDC Foundation. And Ms. Antoniette Holt, the Office of Minority Health Director at the Indiana State Department of Health and past president of the National Association of State Offices of Minority Health. Thank you so much for attending this conference and being with us today.
Dr. Christopher, thank you so much. I appreciate the opportunity to be part of this panel and part of the presentation today. I appreciate the opportunity just to kick the session off, and I'm humbled to join the panelists in today's session and just provide some reflections on the work of health equity, both at the Iowa Department of Public Health generally, as well as in context of our COVID-19 response. It's certainly important for me to say at the outset that every person living in Iowa is important as we work to solve the pandemic. Every individual is critical to our ultimate solution to stop this pandemic. It's also certainly important for me to acknowledge that while I have the opportunity to address you all today, which again is a humbling opportunity, I'm certainly not holding Iowa out as a model. Like many states, we seek to control what we can see, and often we're unable to see where we must, and that's where we must redouble our efforts to really help accomplish our goals. And I think that's certainly apt in the case of our response to COVID-19. Briefly, just a few facts about Iowa. About 90% of Iowans are white and English speaking, although we have significant groups of Iowans whose native language is not English. And COVID-19, of course, makes communication both critical and challenging during these particular times of this pandemic. Secondly, meatpacking and manufacturing employs thousands of individuals in Iowa, many of whom are non-white men and women. Many of these individuals are also non-English speaking. Third, we know that neither infectious disease nor employment are respecters of state boundaries. And we've seen evidence of that in areas of our state where many Iowans, people who live in Iowa, work for an employer in another state. And so those cross-border issues have also created some challenges in reaching those Iowans who have been affected by COVID-19. Fourthly, at IDPH, we have what I refer to as a matrix organization focusing on health equity. We have a group of our staff from across the agency who support developing an understanding of health equity issues at the department and how we respond to these critical challenges. And that group has been a critical partner in helping to sensitize our agency and state agency partners in equipping our response. Fifth, we have critical state agency partners who have been absolutely critical in assisting the department in our response to COVID-19 and the health equity challenges that we face at this time. A couple have come to mind. For example, the Iowa Department of Human Rights, headed by our director, San Wong, stepped into gaps that we identified in our communication and outreach and really facilitated our ability to better equip a response for all Iowans so that our communication can be clear for all Iowans. And they've also been critical in helping us to get connected to community-based organizations on the ground in Iowa to better enable our outreach. Another critical partner is the Iowa Department of Homeland Security and Emergency Management. Director Joyce Flynn, who leads that agency, has also been, of course, the lead for our total response to the COVID-19 pandemic for the state of Iowa, but again has been a critical partner and leader in helping us to do a better job of communicating with Iowans of all backgrounds. Some reflections. While we know there are many non-white Iowans living across the state, COVID-19 has created the need to respond to reaching these Iowans during these critical times to both communicate, which has been critical in our partnership with the Department of Human Rights, has been absolutely important in enabling our more effective communication, and then also in our work to protect these Iowans from COVID-19. Our business and manufacturing community, those employers, understand how important health protection is for their workers, and they've really been very productive partners in working with us to address the challenges that are presented by COVID-19. Our internal staff group that I mentioned and our partnership with other state agencies has enabled our identification of the challenges that we're facing and also enabled improved response to these challenges for all Iowans. And with that, I just want to underscore really how important the team aspect to our response is. So much of this work, I think, is generated by public health agencies in terms of the initial response. But in Iowa, it's been the National Guard and the Department of Human Services, the Department of Education, and so many other agencies, the internal support agencies like our Office of the Chief Information Officer have absolutely been critical. And so it's not possible for us to do a credible, effective job of addressing those health equity challenges we're facing in health without the partnership and the resources of all of those other agencies coming to bear as well. And similarly, the leadership at our emergency management agency during this time has absolutely been critical in helping us to respond to the situation. I mentioned at the outset here that I'm certainly not going to hold Iowa up as an example of the best way to do things, but I do think that we have done a lot of partner building along the way, a lot of outreach, a lot of communication that's really been effective, and it's been effective because of the partnership that we have with other state agencies who really help to round out our understanding not only of the disease, but also of the resources at the community and state level, and bring all of that to bear on the challenges that we face. Again, appreciate the opportunity to speak with this group today, bring the perspective of a state health officer, and with that, I'll turn it back over to Dr. Christopher.
We're now going to hear or see another poll question and move to our next speaker.
Hi, my apologies. Can you hear me? This is Brenda, Jegede. Okay. So I see the responses to our poll question regarding if there's been engagement and work with the state minority health offices or offices of equity. I am very happy to be here today with ASTHO and the other organizations that is spearheading this town hall. Thank you very much for inviting Michigan to participate. Unfortunately, Dr. Jonae Caldoon, who was scheduled to provide an update to you on the work that we're doing in Michigan to address the needs of our racial and ethnic residents, unfortunately, she was called away unexpectedly and asked me to give this information to you, to share the information with you today. Next slide. As mentioned, I manage the Office of Equity and Minority Health within our Michigan Department of Health and Human Services, and work closely at different times with Dr. Caldoon, who's definitely in the forefront of leading our response to the pandemic at this time. And we work closely in her role over our public health administration. Next slide. Just wanted to give an update on the number of cases that we have in Michigan. You can see that we're close to 52,000 cases as of right now, and unfortunately close to 5,000 deaths. And as many have seen in different parts of the country, we have a disparate impact on our populations of color, specifically our African Americans, which only make up 14% of our state population, has 31% of the cases and 40% of the deaths. And one of the things that we definitely have wanted to address is just data collection around race and ethnicity. And early on, our Office of Equity and Minority Health partnered with the Public Health Administration to put on a town hall with our community-based organizations that are providing services to our racial and ethnic population. That was on April 2nd, and I inquired about our ability to provide data by race and ethnicity. So we were one of the first states to be able to do that. But we have, one of the reasons why our area, our Bureau of Epidemiology, had some hesitancy was because of the lack of missing data that we have. So we know that's a concern and something that we've been trying to address. In addition, we see that 30% of our Hispanic ethnicity is missing, and 63% of our Arabic ethnicity is missing. If you're familiar with Michigan, you know, we have a large Arab population, and we do consistently try to provide data for that population. So we've done a variety of things, including matching death records to cases, and really trying to make sure we're identifying everyone that has passed from COVID-19 or have a comorbidity type of death that is related to COVID-19. And Dr. Khaldun definitely wanted to develop a plan to address data. So we've also been trying to match our Michigan Disease Surveillance System data to our Medicaid data. So we're making sure we're not missing cases. That only accounts for about 50%, but it definitely helps us to do some matching there. And we're also working with our Michigan Health Information Network closely so that we can increase our ability to exchange data in real time. What we find is that many times our local health departments are having to go back and put in the data that we need so we can make decisions about resources within the state. Next slide. In April, on April 20th, Dr. Khaldun issued a letter to all clinicians in Michigan, and you can see here that there were three main things that she wanted to share with them. One, she wanted to just bring attention to understanding how the disease was impacting our racial and ethnic residents, and to alert them in terms of things that they could consider in terms of their practice. So one of the first things she mentioned was how implicit bias plays a role in practices, and bringing their attention to implicit bias and asking them to be aware of that, and providing some background and research on data that demonstrates that. Also connecting them to some resources. Also wanted to definitely recognize that our strategies around isolation and quarantining is not always possible for some populations, and wanted to make them aware of how that could be difficult, and to recommend that they actually talk with patients to see what their needs are and connect them with resources. And then finally, you know, talked about the social determinants of health, and definitely how they impact different populations, and it can impact their access to care and just their health outcomes, and connect it again to some of what we call our 211 resources, but also resources to connect with insurance or different services. Next slide. Also in April, actually the same day, April 20th, was a big day in Michigan. Our Governor Whitmer, signed an executive order to establish a Michigan Coronavirus Task Force on Racial Disparities. And you could see that there's a charge to look at a variety of things, including lack of data, and again, bias in testing and treatment. And then also we wanted to determine permanent infrastructure and policy needs for long-term planning. The task force is led by our Lieutenant Governor Garland Gilchrist, and there are about 25 members who have been assigned to that task force. And there's also a community action team that's made up of more stakeholders within the state. The community action team is looked at as a larger group to vet some of the recommendations and strategies that come out of the task force, and to make sure that we have more people involved in the strategy. I've been involved with the task force for about 3 weeks now. I was asked to lead one of the work groups, our strategic testing infrastructure work group. And immediately what I heard from members who on the work group is made up of task force members, of community action team members, and then of others. And immediately was asked to set up more testing sites throughout the state. So we did identify and come up with a plan to expand 20 what we call neighborhood testing sites. We really wanted to partner with trusted community entities, community-based organizations, so that we could reach out to our racial and ethnic residents. 7 of those 20 sites, 7 were identified in Detroit and 13 in other areas of the state. And like many around the state, we had challenges in terms of supplies and lab capacity. So one of the things that we've done in order to do this expansion, the 20 sites, in addition to 5 large-scale drive-through testing sites, we have issued a immediate bid that went out last week, where we're asking for a contractor to be able to come in and provide all of the medical supply services for these sites. Those bids came in yesterday, and we hope to have a contract in place soon. When we were identifying the sites that we wanted to utilize, we looked at a data-driven strategy. So a part of that looked at CDC's Social Vulnerability Index. This is a process that was shared with us by the director of the Office of Equity at the Ohio Health Department. So we looked at social vulnerability, looked at things like socioeconomic status, household composition, minority status, and we also looked at comorbidities. And then we mapped all of the existing testing sites in the area and how far, and then we determined that way where we would expand. And part of that final analysis is collaborating with the local municipalities and other stakeholders to make sure that there are not some things within those areas that we're not aware of, to see if we need to change the focus on those census tracts or zip codes. And we also looked at expanding a mobile testing model that is a partnership with Ford, Wayne State, and one of our CBOs. Next slide. We have several efforts within the state to expand our testing, support from a variety of areas. We have over 200 sites. Our Dr. Caldoun has done a lot in terms of expanding testing criteria to include those with mild symptoms, and right now we're testing those who are working. Our goal is to get up to 30,000 tests per day. Just the beginning of April, we were at 5,000, and now we're around 16,500. And part of that expansion, the neighborhood testing sites, will help us to get to the numbers that we want to get to. And there is a focus on our nursing homes and our jails and our homeless shelters, a lot of the areas that our racial and ethnic populations were concerned about. Next slide. We've also engaged in our contact tracing initiatives. In some of our areas of Michigan, Southeast Michigan, there was some areas that were overwhelmed with the ability to respond. So we have on our website asked for volunteers and completed training for those volunteers. And we're doing some communication or promotions to let residents know when they see that 517 number. That's a Lansing, number. So please answer the phone and why it's important to answer the phone and who's trying to contact them to get information. Next slide. We also have been working on our isolation and quarantine procedures. We have some support by community action agencies and other organizations to distribute supplies to homebound residents, including cleaning supplies and some things like masks, things of that nature. So we want to utilize that in our neighborhood strategy. And we're also making sure to connect with resources. We're using navigators to make sure that we're informing our residents of all the things that they may have access to, and including unemployment benefits, cash assistance programs, et cetera. We actually have a pilot that we hope to launch any day now in Southeast Michigan, where there will be somewhat of a wraparound services for people who may not be able to quarantine in their homes, and they would be able to go to this location. Next slide. We also worked really closely with our communications area. We know that not everyone has access to the online and resources, so we wanted to make sure and share information in a variety of modalities, and wanted to make sure that we're looking at community level resources and making sure things are translated in multiple languages. And we also instituted some videos called Doing My Part, where we have community leaders giving messages to residents. A lot of that is in our Southeast Michigan, Detroit area, Detroit, Wayne County, and Macomb County area, to support and get people to test and talk about the importance of it. Next slide. We also, Dr. Caldoon reached out to us, and we've had a lot of discussion about how some of the recommendations are not always realistic or are not options for some residents. So we developed some communication in terms of what to do if, for instance, you don't have running water, or if your home doesn't have a separate room, or you don't have an extra bathroom, or if you're like, my husband, who might be hesitant to wear a mask because of how people may respond to him. So we talked about those things. We gave some resources and tips on how to respond. Next slide. And then finally, our area, our Office of Equity and Minority Health, just developed some short-term and long-term strategies around mitigating the transmission. And these are some of the ongoing strategies that we are promoting in terms of looking at utilizing a racial equity assessment tool in our programming, really looking at developing a plan to reduce structural racism and bias in our systems. So these are just some of the recommendations that we have, and that's included on our website. Next slide. Just this is our main site. We have a lot of resources, including all of our executive orders, our advertising, information about the materials that I mentioned. And then I believe the final slide. Yes, so thank you. Tried to include a lot of information in a short period of time, but I hope you were able to glean a little bit about what we're doing to respond in Michigan.
Thank you, Brenda. That was an amazingly helpful presentation, and our hats are off to all those that are working so hard in Michigan to help health equity to become a reality in this critical time. And now we're going to have another poll question before we move to our next speaker.
Hi, good afternoon. My name is Angelina Esparza, and I bring you greetings from Houston, Texas. I wanted to share with you the work the Houston Health Department, a team of dedicated and talented folks have done over the past few weeks in response to COVID-19. We are humbled to ask to share this experience in our strategies, and our strategies are really focused on the following three premises. That one, health is local. Two, understanding the data will help us better plan for future successes. And three, success really comes with and through partnerships. So with that, next slide, please. I wanted to give you a current status of where Houston is. So when we say Houston, the Houston area is really the city and then many surrounding counties. So combined, and this was data from a few days ago, we had about 14,000, almost 15,000 cases. In the city of Houston, we had 5,698, and then within Harris County, because we have both a county and a city health department, and a large portion of the city sits in the county, but not wholly. The county represents 3,809, with deaths a total of 382 for the area. Next slide. So these are two maps that I want to share with you. The top map, the one in purple, actually shows the cases within the area. The lower map on the right-hand side, you'll see the green map, or what has shades of green, is the social, economic, social vulnerability score in the index. And I think the previous speaker just referenced this as well, but in looking at hazardous events like disease outbreaks, it's important to know the factors that contribute to communities' ability to respond effectively. So from the leadership level down to the block level, to do this effectively, many have used a variety of tools, and CDC offers the Social Vulnerability Index. So the index includes a lot of factors, includes poverty, lack of access to transportation, crowded housing, and other things that may weaken a community's ability to prevent human suffering and financial loss in a disaster, and also be able to respond effectively. So in these two maps of Houston and the surrounding area, you see both where, so if we look at the Social Vulnerability Index first, you'll see that it has really impacted the east side of the city. That's where we have some of our challenges from a socioeconomic standpoint, also from other social factors, access to health care, crowded housing, or unaffordable housing, unhealthy housing, right, or housing that is unstable. So you'll see that. Now, if we look at the map of the cases, you'll see that it overlays quite nicely with the social vulnerability map. So while this probably didn't come as any surprise to us in terms of what we knew might happen and could happen, had been told for many years would happen when we look at health disparities and the inequity that has continued, I think it does give us some indication of what we need to do moving forward. So with this information and with this data, we know that data is important, and it's not necessarily at that state level or national level, which while those are very important as well, it really is getting down to the individual municipalities and then even to the neighborhoods and the block level to understand what those challenges that people are facing on a daily basis. This information helps us to plan and implement both for testing sites and also creating specific tailored interventions and enhancing our established partnerships so that we can respond effectively. Next slide, please. So here are some of the strategies that we've undertaken. As I just mentioned, the data is really important in really understanding locally, when Houston reports its death information, it actually includes a couple of key elements. It includes the age in terms of the decade of the person who passed, information, their race, ethnicity, and then also whether they had any underlying conditions. So I think being able to describe pretty effectively who is being adversely affected by the disease and who is succumbing to the disease is very helpful in putting in having a narrative that actually lets people understand in their community who are their fellow Houstonians that have passed from the disease. So in addition, when we look at contact tracing, So the process of contact tracing in and of itself has really been heavily focused in epidemiology, but what we've done is actually increase the capacity in this way, because we have trained the people who are doing contact tracing to actually start asking for social needs for the persons under monitoring or under investigation. So they look at social challenges, any barriers that would keep them from successfully isolating themselves or staying quarantined, and challenges can include inability to work and therefore loss of income, food instability, inability to pay housing costs. And so how we address the issue is partnerships with local nonprofit organizations and other governmental agencies, and develop a way to effectively address the needs of the individuals and in some of these communities that were specifically. So flexible funding has also been used when there's limited or no resources could be found. We also have focused partnerships to address and support some very specific high-risk populations. For example, the unhoused or marginally housed populations. These are partnerships with federally qualified health centers called Healthcare for the Homeless here locally, and the Mayor's Office for Homeless Initiatives. The goal was to identify those living in homeless encampments or shelters or on the streets and provide them a testing in a safe manner and provide access to medical care and housing for recovery. So temporary housing was established with the purpose of isolation and quarantine, and also it was provided for the chronically homeless with support of both HUD and local housing authority. An individual would be identified, a cab would be, which was outfitted with appropriate PPE and taking all precautions, would be sent to take the individual to a clinic for testing. And if those individuals are found to be positive, and they need medical care, then they are taken to either a hospital or to this quarantine facility. And so the individuals are followed up as needed and provided other social supports. And I think while this has mitigated some of the issues among the unhoused, permanently unhoused in terms of permanent homelessness, the marginally housed, those who might be couch surfing or live in multifamily living situations where there are multiple families living in a one-bedroom apartment, those individuals are still a particular need in terms of a high-risk group, and yet we are still working to try to figure out how really to address that population effectively. Another group is the disabled and the elderly. The health department is very fortunate to be working with the Area Agency on Aging, actually housed within the health department, and they have a call center. So that call center has received many calls from those who are elderly who no longer drive and can't get to any of the testing or drive-through sites, and then also those with significant disabilities that would keep them from going through any of the free test sites that the city offers. So what we were able to do is actually work with a private company who donated a number of tests. They are in-home tests, and it comes as a package. They come to the home. They actually do the collection. They send it off to their own private labs. The labs come back with the result, and the result is communicated by a physician or nurse practitioner to the individual, either via telehealth or in person, depending. And then the laboratory services actually works with the health department too, so that we can collect and continue with contact tracing as needed. So that group is called I'm Aware. That has been a very successful partnership. They provide the reassessment if a person needs any additional assistance via telehealth, and it really has allowed us to create an opportunity to test individuals who, quite frankly, wouldn't have very many options to be tested during this time. In addition, we've looked at incarcerated populations. Both city and county have partnered to continue to provide support and increase testing within the jail populations. We continue to see growth in these numbers. A particular concern of those who are released back into the community. The city of Houston had already had a reentry program, so that reentry program has been very helpful in making sure we continue to follow those individuals, and then also work with nonprofits to help support them once they are reintegrated into their communities. However, we are working quite diligently to provide reports and compile guidance for infection control, disinfection options, and also to decrease closeness and distancing and increase distancing, but it's very difficult among this population because there isn't a lot of room. So again, another challenge that is still we're working on to address. There's also been strike teams that have been set out for congregate housing to help those and assist those, particularly in priority nursing homes and retirement communities. The health department has partnered with Houston Fire Department to visit priority nursing homes and provide guidance and information on disease containment and infection control. They've also set out recommendations for testing, and they were able to actually bring testing to the sites for local organizations, particularly the United Memorial Medical Center, who has done some testing within the retirement centers and also within the jail systems as well. We've also used what's called ETHN, Emerging Telehealth and Navigation. It's a telehealth service via the emergency medical system to triage individuals in the field and provide appropriate care in appropriate setting. So if someone calls 911 and an ambulance or a vehicle, an HFD response vehicle is sent out, if they realize that this is not an emergency case and not necessarily needing any EMS services, they have the ability to pull out a tablet and actually establish a connection with an emergency medical physician on the other side of that tablet, so telehealth. Establish that connection. The physician can then review the case and make some determinations as to the next steps that are appropriate for that patient. It could be going to a testing site and issuing a number right then and there and setting up a time for that individual to go in. It could be going to the homeless, the FQHC that we set up for homeless testing. So based on the individual's needs, the EMS can actually triage in the field and be able to meet the patient's needs and connect them to the right resource. The one last thing I want to talk about as well is this idea of complete communities, and this is an innovative project. This was actually something that had been going on prior to any COVID-19 issue. Complete communities was the identification of areas within Houston neighborhoods, specifically within Houston, that had issues related mostly to socioeconomic indicators, but also really had maybe poor housing, poor education, limited access to health care, poor infrastructure, maybe not having a lot of areas for people to actually engage in terms of having a job within the neighborhood. And so a very ripe for economic development. And so what ended up happening is that this gave us, next slide please, an opportunity to do a little bit of a deep dive with the information that we did know about those complete communities. So we're going to have to toggle between these two slides. These are two examples of the complete community. This is Sunnyside. And what you'll see, and I want to bring your attention to, is the median income about $26,000. If you look at the descriptors, you see that there's quite a few of SNAP recipients in this area, and the population is insured, but it could be insured. And if you look at also the age of the population, it's an older population. If you can toggle to the next slide, please. So if you look, this should be the Gulfston slide, and I apologize, I got kicked out of the webinar, so I cannot follow along with you, but this slide should say Gulfston at the very top. And what you'll notice here is while the median income of $27,600 is about the same, we have a very huge distinction in terms of the amount of uninsured in this particular community. Same thing with SNAP, so you still see a lot of SNAP recipients in this area. So while we understand that there could be some indicators that are the same, it wouldn't necessarily be, someone might look at this in the face and say, oh, well, these incomes are very similar. We're probably talking about a similar population. But in this case, we're talking about very different populations. In Gulfston, you'll see a younger population, a newly immigrated, a very immigrant population in that area. Some established individuals in that area as well. And in Sunnyside, you will see more of a settled community. It's historic, and so many people have been there. Probably less on the uninsured, but some of the same needs, some of the same challenges. But the racial and ethnic makeup of these two populations again are very different. So just to illustrate that while we've been able to identify those neighborhoods of interest, in particular who we know that have been underserved historically in Houston, how we can use this data to now better address the needs of the population in regards to COVID is very important, and then also how we can work to establish and enhance the partnerships that we already have in the community to effectively meet the needs of our community. And then the last slide, just wanted to thank the work and recognize the work of the entire organization, but specifically the leadership of Mr. Stephen Williams, the director, and Dr. David Purse, the Public Health Authority, with the incident command structure leaders, both Marlene and Decretia, and to all the staff, especially Ms. Jennifer Graves and Dr. Latasha Gale-Lowe, who helped compile the information for this team. Thank you.
Thank you. Thank you, Ms. Esparza. It is so refreshing to see what people are really doing to experience a different narrative about this COVID-19 crisis and the response of qualified, caring people. We will now have another poll question before we have our last panelist.
The poll is, to what extent do you feel that your organization is able to address health equity during this COVID response phase? We're collecting the results. Terrific. So 58% said somewhat, 20% said a great deal, 17% said not very much, and 5% said not at all. Thank you.
All right, good afternoon, everyone. My name is Antoniette Holt. I am Director for the Office of Minority Health in the Indiana State Department of Health. I also have the privilege of being the past president and vice president of the National Association of State Offices on Minority Health. I do have some slides. Thank you, ma'am. You can go on and advance to the next one. Just give you a little bit of information about NASOMH. NASOMH has been in existence for the past 14 years. NASOMH is comprised of our state offices of minority health or minority health entities. So it could be called an Office of Health Equity. It could be called the Office of Health Equity and Minority Health, as you saw with Brenda's office and different things. And so we try to support and recognize, we try to support and represent those offices. Our efforts focus on minority health elimination. We are very good conveners in regards to minority health and health disparities. And we're a national leader, partner, and advocate for policies, programs, and services that help improve the health and well-being of racial and ethnic minorities. And we do that through our network of our territorial offices. Currently, right now, I know that there are 48 operating state offices of minority health and minority health entities that exist throughout the United States and U.S. territories. Next slide, please. And so, as being part of NASOMH, I also, my day job is a director of the Office of Minority Health. And for most of you, life has changed over these past 60 days in regards to COVID. And so COVID response has just become a part of way of life for us. We get up, we come to our home offices if we're able to work from home or different places. And we begin our process of the day involving COVID and everything we do. And as a state director of the Office of Minority Health, we have been tasked with that, and especially dealing with vulnerable populations throughout the state. Just to give you some perspective of what's going on in our state, we currently are addressing our disparities with Indiana's Health Disparities Task Force. Our first meeting was as of yesterday We've been tasked by the Indiana Black Legislative Caucus to produce 2 reports. One is a corrective action report. The second is a report addressing prison populations as well as juvenile detention centers. And one of the things that's made us unique is the conveners, or the people that are in charge of the task force, are the 3 leading entities in the state that focus on health disparities. So you have the Indiana Minority Health Coalition, which is the not-for-profit arm of minority health in Indiana. They are able to do things such as direct services with their coalitions. There's 22 active coalitions throughout the state. And then also they can do some things that we cannot do as the State Office of Minority Health, whereas they can go before a legislative body. They can do different things with legislators. They can do different things as far as direct services that we can't do. Then we have our Interagency State Council on Black and Minority Health, which is a statute council, which is governor appointed. And they are tasked to do an annual report every year to the legislative body of what's going on in the state in regards to racial and ethnic minorities. And so having them on board helps us in regards to not only with the task force, but it helps us next steps going forward, what we'll do together. And then we have our office, the Office of Minority Health. Our priority areas, similar to what you've heard previously, we're looking at testing, we're looking at contact tracing, behavioral health in regards to mental health, improving data collection, racial ethnic minority deaths, and then education, outreach, and public awareness is kind of what our effects are. And so I know time is getting from us. So you go to the next slide, please. And I'll talk about some challenges that you've probably seen or heard of. Some challenges that we're having is one, disparities is not brand new. Even though it's highlighted and people are shocked and awed, this is not a different drummer and a different beat. This is something that's continuously happened, and we are constant educators in regards to that. One of the things that this opportunity has afforded us is to be able to highlight how the need for making changes in eliminating disparities. And what I mean by that is making systemic and structural changes within the agencies, within entities, that we can really make effective changes as moving forward, not just for COVID-19, but other diseases and things that we handle and take care of. Other challenges that we face as state offices of minority health and minority health entities, or you yourself as a community-based organization, is sustainability in regards to our offices. Having that support, whether it's financial resources, different things, being able to continue to withstand the test of time, especially if you have constant administrative changes, like some states do with administration change constantly with your show or with your governor or whatever have you. So it's always a constant reentry of the wheel or re-entering the building and having to reaffirm and re-explain and understand the importance of health equity and eliminating health disparities. And then having support. I think when you have support, it makes a great difference in regards to your sustainability, support of your leadership. We are very fortunate now at this time in term, Dr. Box is my state health officer. My boss presently is the chief medical officer, which is Lindsay Weaver, and they're very supportive in efforts in regards to trying to address health disparities, especially this COVID pandemic. And outside of that, we were looking at health equity and all policies and what we can do. Having support partnership-wise nationally. We have the National Office of Minority Health, but being supportive of your state offices of minority health and minority health entities, making sure they have the resources, not selling minority health cheap, which sometimes that happens a lot because there's things that we would want to do in regards to addressing minority populations and things, but we don't always want to make the invested time, interest, and money. And so it's very important that we make sure that we're investing that with our states. Next slide, please. So lessons learned that we've learned here at the COVID table. Don't go to the next slide, but just hit one more time. Thank you very much. Lessons learned that we've learned sitting at the COVID table. There's 3 ways that you can get to the table. Either you're invited, A lot of people have been fortunate in regards to their states understanding the importance of having minority health entities in the beginning stages of planning and their emergency response. And so that makes a difference in regards to where they're at in addressing concerns amongst vulnerable populations. And then the other thing is in regards to bringing your own seat. If you have not been invited to the table, you're bringing your own seat, pulling it up, making sure that you're being the sounding alarm, that people are addressing these vulnerable populations, marginalized populations within your state, and they're not an afterthought, and they're not being gone to at the last result to try to make sure we're effectively making change. And then some people are being still left out of the dining room, okay? And so it's very important that if you get left out of your dining room, you go to your neighbors, you go to those entities and peoples and individuals and organizations that are going to help support you in your cause. Maybe you cannot get to your state health officer, or maybe you cannot get to your governor, but you have entities within the community that can support the efforts of addressing the needs and concerns of these marginalized populations. And so going to your neighbors for help, making sure they're sounding an alarm if you necessarily cannot, is very important. And then the whole entire point of the lesson learned is don't get left behind. Make sure that this is the time more than ever that we are courageous, that we are making sure that we're standing sure, that we are effectively fighting for those that we advocate for on a day in, day out basis. And so whether that's your state office of minority health, whether that's your minority health entity, whether that's your community-based organization, whether that's marginalized populations that you know are experiencing. I saw something come up in the thing in regards to our Amish population. There's different populations, our pregnant women, these different things that are experiencing adverse barriers unnecessarily. So doing testing in areas, but then requiring people, maybe undocumented people, having certain types of presentation of where you live and different things like that, or you're sending them an hour away to get tested from a site that's just down the street around the corner. So we want to make sure that we are advocating for these different marginalized populations that are experiencing these adverse barriers and things, community health workers, that we're including them, that we're making sure that they're part of the process and not just, again, an afterthought. Next slide, please. And so what does the future look like? The future addresses the challenges of funding, because it takes money to buy land. So we're addressing the challenges of funding, making sure that the appropriation that you're getting from the federal government is something that's going towards how are we communicating to these communities that are experiencing more adverse effects? How are we staffing? I know a lot of states are going for hiring contact tracers and different things. How are we training them, making sure they're culturally, linguistically appropriate and ready to be able to do contact tracing, making sure that we create a standard methodology of data collection. There's no standardization in regards that we have for collecting. I know in our state, in the beginning, people were just collecting name only and numbers because you people providing tests. And so you're also regarding you are collecting demographic information that's going to help you. So we want to make sure that we are ensuring that we have the necessary funding, staffing, standardized for that. And then also we want to make sure that we're meeting the need of geographic regions and things. We want to have a collaborative effort, both on the public and private organization, eliminate a lot of the silos. And I know a lot of this is preaching to the choir, but I think it's very relevant and important to what we're doing. And then also most state offices of minority health and minority health entities are sitting at the table. Involve your state office of minority health. They have a far-reaching relationships and things within their state, universities, local levels, different things that can help you be more successful in these communities that are at most risk. And then also address the overarching systematic and structural barriers that continue to be created that stand as a stumbling block for our disparate populations. And I think that's it for my slides. Am I correct? Yes. So thank you.
Thank you, Antoniette, Holt, and all of the speakers. We're not in a public face-to-face situation, so we can't applaud you, but I wish there were some virtual way we could express our appreciation. Our timing is going to be a little different than originally planned. We're going to have some time for discussion, and then we're going to move into entertaining some of the questions that have come in via chat. So first of all, we hear a lot about working together. And so my first question to any and all of the panelists is, are there specific functions that you think would be best accomplished in terms of response and recovery to achieve greater equity by sharing resources and information? Can you give some examples of where health departments are sharing or where you're sharing with other entities that have a direct bearing on the outcome in this pandemic? Any of the panelists?
Okay, I'll go.
Okay.
I think one example that we have, they brought the Office of Minority Health on board at the State Department of Health in regards to their emergency response. And so each command call that we have in the morning, in the evening, I'm a part of. I have an opportunity to be able to hear what's going on as far as the testing, the number of people that may have passed away, the number of people that they're testing. They've involved me or the office as part of trying to reach out to disparate populations. And so then we get to be a bridge that garners relationships between the State Department of Health, as well as local community organizations, churches, different things to help them be a part of it. Giving clear explanation and understanding. We were doing some studies in our state that's affording more testing to be available amongst vulnerable populations that otherwise wouldn't have access to it. And so again, being at the table, being involved, I think is very important. It allows us to be able to show also camaraderie. It gives assurance to the community where they may be hesitant of government entities and agencies. And so this allows them to be able to see and establish trust. So then if there are things that come up, because this is an everyday changing disease, our process, we don't know what's going to happen from day in, day out. And so when you're able to establish that relationship, you're able to establish trust, you're able to show that you are taking an active interest, it's going to produce a better outcome.
Thank you. Gerd, I see you're going to respond to this question about partnership. You certainly mentioned it in your presentation. Would welcome any thoughts you have.
Yeah, Dr. Christopher, thank you. I've seen in the work that we've been working through with the COVID-19 response, partnership has just been critical for us in opening doors. We can only see so much, a lot of very important aspects of health and health equity from sitting in our health seat. But bringing in, for example, the Department of Human Rights really has opened up opportunities to reach populations that are not normally within our view of sight. I wasn't aware, for example, that we had a number of Swahili individuals within the state, Nepali, Kuwana, others. And so connecting with our Department of Human Rights has really opened up additional opportunities to reach populations that we haven't seen. And I mentioned Homeland Security as well. Their expertise with navigating through these responses has also kind of enabled us to ride on the infrastructure that they have in place. And that frees us to think more critically about how we reach those hard to identify and hard to reach populations.
Thank you for that. And I'm going to jump around some. Now, these questions have come from you as participants before the day today, but I'm going to suggest that I'd love to hear what lessons you think have come up in this experience that apply to understanding and acting on the idea of health in all policies. We're hearing about housing, and we're hearing about immigrant populations and Amish populations, other populations that might be isolated or separate from the main healthcare infrastructure. But let's move also to the idea of health in all policies and what we're learning from this experience that we should carry forward. Again, and I would invite all of the panelists any of you to respond, particularly those that we haven't heard from so far in response.
This is Angelina. I will talk about that a little bit. I think the policy discussion is really important and shouldn't be overlooked. I think part of it is that we have to change the narrative on how we talk about health disparities and health equity. And really, I think there's still kind of an us-them idea of how health equity and health disparities work, rather than this is a very definitive time for us to understand that the disease impacts the entire community, the entire city, the entire state, et cetera. We have to rely on each other, and the weakest link within any of those systems will break the system. And so without being able to adequately prepare and support our citizens at every level, then we really do the disservice to the entire community, city, state, country, ultimately. So I think part of it is changing the narrative and really understanding the impact of having the disparities, having the inequality, and really a need to change if we're going to do it for the good of the country. Clearly, there's some of us have been doing this for a long time, and because we care about individuals. But if we need to change the narrative and make sure that we are optimizing this time, I think I look forward to being able to make the policy changes necessary to give us a healthier community and a healthier nation.
Okay, thank you for that. Any other thoughts on policy changes? I heard so much about marginally housed and homeless. Any specific thoughts about changes we might make in our housing policy, or any stories of efforts that are underway in your jurisdictions? Hearing nothing from my panelists, then we will move to another question. Before I do, though, any other policy responses? And that was such a wonderful framing. It's not us and them. This moment is certainly showing us that we are all in this together, for sure.
You know, Dr. Christopher, this is Garrett Clabaugh. I would just say, it's just repeating what you said. You know, in my introductory remarks, I made the point that, you know, what we're trying to do here is reach, in our case, we're trying to reach every resident of Iowa. Everyone is valued, and everyone, in the case of COVID-19, represents an important individual that we need to reach with communication and support. And so I think really kind of embedded in the emergency response is that, that the realization that this really is health equity at its core. It doesn't make it any easier to meet the challenges, but I think at the core of the argument here really is a respecting of every individual.
Okay. I am having some internet challenges. Can you all hear me okay? You can.
Yes, we can, Dr. Christopher. If you like, I can provide a question from the chat line.
Well, I was about to invite you to do that. Thank you, Melissa. Very good.
So we have one question. We have quite a few questions, and I'm just going to put one real quick. So in this moment, health departments and health officials have higher moral and statutory authority than other non-crisis moments. Do any of you know of local or state examples where health departments have advocated for equitable policies, such as decarcerating prisons and jails, encouraging rent cancellation and increased renter protections, and or shutting down businesses for not following appropriate protections for their workers? So just more a question about the equitable policies that are there any examples of that from the panelists?
Examples that I have in regards to what's happened in Indiana, I know our state health officer, Dr. Box, has created, in regards to people getting treatment after they've been tested with COVID. I know that getting the COVID test, she has created kind of overarching doctor's note, whereas some people needed a doctor's note, different things. She's created into executive order. So then that way people can get the testing for free, and then working with insurance, different things as far as getting the test done. And now they're looking at efforts in regards to how, after you find out what your results are, what the next steps are. And so I know that she's also working with Dr. Sullivan, who is over our Family and Social Services Administration, of what's going on. So those are some things, barriers that you can break down when it comes to people getting tested. Rather than, some of our testing spots afford you an opportunity to come up and get tested rather than going through the registration process, but you have to check out specifically what area, a location that will do that for you, but trying to increase the spread of reach of people, making sure that people are getting tested. So those are the things that, you know, some people, again, may be undocumented, different things like that. They may not have the certain ID that you need. So what can we do to do that? Looking at maybe a bill from the house, looking at, if it's not necessarily your house, providing a number so we can reach you in regards to that you get your testing done. These are things that we're looking at to how we can kind of diminish those barriers that exist and making sure that we get the test to the people.
Thank you. Melissa, I'm going to ask one of the other questions and then turn it back to you. Often health departments and organizations are hampered by regulations, which is part of what you were addressing, Antoniette. Regulations and practices that make it challenging to hire contact tracers and to move forward with some of the things that must be done now. Can either of you give examples of where you've been able to overcome or alter existing regulations or administrative barriers to reaching the populations that you need to reach? Particularly with undocumented, or yes, who's speaking?
So this is Angelina. I mean, I'll tell you that in terms of being able to hire contact tracers and surge staffing, being able to work with the CDC Foundation and through some of the other mechanisms that CDC has provided has been helpful, but I think there's still challenges of procurement and all the other regulatory and process and procedures that local health departments have to go through that still make it a challenge to be able to react quickly. So I think the temporal part of it is always a challenge.
Yeah, I did hear someone mention they were partnering with community action agencies. And I think that this idea of partnership with existing community workers and community organizations is a very important potential, opportunity for leveraging existing resources and existing relationships. So thank you for that answer. Melissa, I know you have lots of chat questions. Do you want to give us another one or two?
Sure. So one question that we had is, how do people see the housing of the homeless changing after the immediate threat of COVID-19 is over? So if the panelists could speak to how they are addressing homelessness.
Melissa, if we don't get a response, I'm going to invite you to give us another question from the chat.
This is Angelina. I can add just something very simple here that's happening here locally in Houston. I think this is going to be a huge concern. There was money set aside by the mayor to provide some assistance, about $15 million in rental assistance. Within the first day, the website was kind of overwhelmed by the number of applications. So I think this is kind of something that we know is happening now with a lot of the states and counties having in place policies that prohibit evictions. Once those are lifted, I think this is going to be an emerging problem moving forward.
Yeah, appreciate that perspective. Yes, indeed. Were there other responses to this issue? And the affordability of housing is really, underneath all of this. And then we get to economic income and opportunity. But any other thoughts on the homelessness issue?
No, I agree with her. I think it's an issue that we need to take up too, looking at the overarching perspective as far as health and how it affects, if you had a job 2 months ago and now you don't, and then what rules were put into place to try to help you from being evicted the first month or two, that is ending. So what are we going to do when rent is due and you don't have the resources to do it? how are we going to help them not only just physically find a place, but mentally and emotionally helping as well too. So I know that our Family Social Service Administration is also working towards trying to address those issues as well. I don't have set specific guidelines presently now, but I know that we're looking at that even in the Health Disparities Task Force of how we're going to address homelessness as one of the main issues that is happening amongst our vulnerable populations.
Mm-hmm, mm-hmm. I'm going to ask another one of the questions that came in, and it's really central to this issue of equity right now. It's a question of narrative, it's a question of framing. While it may be expedient to point to possibly genetic differences, individual behaviors, or other racialized myths and narratives as the cause of COVID-19 disparities and inequities, panelists, what do you think is needed to foster much needed actions to address social justice and health equity issues? What do we really need to have happen in this country to move beyond this immediate crisis and the ability to blame, if you will, those who are suffering disproportionately, or to dismiss it as something that's not in our hands? Any thoughts?
I think we need clear messaging. I think a lot of messaging that we have presently now can be confusing to some of our populations, or I think we also need to keep in mind, as we had heard in our presentations, the importance of those barriers that exist for different populations. If I live in a multi-generational home, telling me to space out is not going to be conducive. So I think that's very important in how we talk to people. Who are our messengers that are going forward to talk to the people? I think we need to have things clearly class appropriate. So we need to have things translated, and we need to have interpreters for those that are limited English proficient. I also think we need to bring to the table that the barriers that had already existed prior to COVID and how that's creating even further more barriers now. And so if you already had underlying conditions, if you are already despairing as far as economics and different things, and this has been put on top of you, what do we need to do to address the underarching effect, not just COVID? So I think those are some important issues that we need to bring to the table. And we need to be honest and admit that if we've made a mistake or we've not done whatever have you, that we've done it and we got to move beyond that. And then we need communities to listen to their counterparts when they're telling them to stay home, protect others, protect yourselves, because that's such a message. We're getting so many mixed messages, especially in regards to social media. People don't know who to believe, because it changes, varies from whether it's governmental, whether it's local, or whatever have you, whether what news does or different things. And so people are confused as to who do they trust. So we need to make sure that our messaging is clear, concise, and is on point. So
Thank you.
The whole time.
Now, we've talked a lot about physical health and the inequities and disparities associated with the illness and the disproportionate death rates, but mental health is a critical issue as we move through this trying moment in our societal development. What are your health departments doing, or have you taken on the issue of mental health in the midst of this, both mental health as a result of the pandemic and the mental health challenges that predated and will follow the pandemic?
Dr. Christopher, this is Garrett Claybaugh. I'll weigh in on that. In our state, we've been doing some work relative to mental health, children's mental health in particular, but mental health more broadly. And we've got partnerships developing between our Department of Human Services, who's the mental health authority in the state, and the Department of Public Health, who's the substance abuse authority. And those partnerships have been developing along the way. One of the things that we've done as we've developed that partnership is we've put out a uniform communication strategy through a website called Your Life Iowa. And what that website has really enabled us to do is kind of position ourselves combined with regard to mental health, substance abuse, gambling, suicide, and really put a single forward-looking face to the public as it relates to accessing services that are provided by the state agencies. And of course, while we're anticipating certainly coming into and through and beyond COVID-19, a higher prevalence of mental health and substance abuse issues, I think we have yet to really see what the real impact is going to be. But I think so far we're well positioned for that. We'll see what the actual demand for services will be, but undoubtedly, with any disaster, there's the impact of the disaster, and then when it resolves, what I refer to as the tail, the kind of prolonged effect of that higher level of demand for services will prolong itself. And so I think that's where some of the challenges will come into, is how long we'll be able to prolong access to services at that higher level, even beyond the immediate resolution of the emergency.
Mm-hmm, mm-hmm. Thank you for that response. I can't believe our time is almost up. Again, I want to thank all the panelists, and I do want to invite Melissa, if you can combine some themes that have emerged from the chats. If you have one more chat question, I certainly would invite it.
So we did have there are two questions, I think, if I can. So one, there were quite a few questions that came around. What are we doing to support undocumented residents around testing costs, medical costs, and critical services? So that question came up very frequently. And then I think we have one more just closing question I can ask, if we can have someone reply to that.
The undocumented access to testing, and I would imagine care as well. Anybody?
Right. Medical costs and critical services is a question that came up quite a bit in the chat lines. And then the final question that I think is also a really good one is the reference to bringing your own chair to the table. What are specific things that one can do to generate power and pressure in states where equity and health disparity are neglected? So I thought they were both two strong questions. So one, could someone from the panelists speak to their efforts to support undocumented residents? And then in terms of what everyone can do collectively to generate power and pressure in the states.
If I can get an answer to that, because we have 3 minutes left in our time together.
So this is Angelina. I'll just talk about the immigration status of individuals as well. So yeah, I think this is a ongoing issue, ongoing problem. I think has been exacerbated by the local, or by recent, not local, but recent policy changes at the federal level related to immigration status and how immigrants are treated. So I think continuing to establish dialogue and establish trust within those communities is important. Here locally, all the testing that's available is available free of charge. We're not asking for any information, so people can come up and feel free and confident that when they're being tested. Now, if they are positive and they need additional services, we do have a mechanism to provide some of those services. Although, this is an issue that there's lacking services, and we need to kind of lean forward a little bit on this one as well, particularly those of us who live in border states who have a significant population of immigrants.
Thank you for that answer. And I'm going to take that last question. This is a time that should catapult us as a nation into a very focused effort at healing our divides and really giving up, jettisoning the false ideology of a hierarchy of human value. This is a time that should lead us to embracing our collective humanity and understanding that we are in fact interconnected and interdependent. And the blessing in this terrible moment is that we see that. We see that from the standpoint of our economic interdependence. We see it in terms of our vulnerability. We see it because we are being isolated from one another, and we realize how much we need to be with one another. So I am truly hoping that this experience will lead us to a concerted, comprehensive effort to heal our divides and to jettison permission to devalue any human beings based on absurd mythologies and differences. I'm pleased to say that there is work going on to bring that about at a congressional level, and I would say stay tuned. You will hear more about a proposal that we engage in a collective truth, racial healing, experience and transformational experience as a country that focuses on our common humanity. And that is, I think, a very important step in the work of overcoming both this challenge and the challenges that have made so many more vulnerable. I've been honored to moderate this panel today, and I definitely want, could I have this slide, the resource slide? I definitely want to draw your attention to all the organizations that partnered. They're there on the slide. I also would like to ask you to be sure and fill out the evaluation questionnaire that is available for you to fill out. I know the slides will be made available. I want to give my applause to ASTHO and to all of the partnering organizations, and I really hope you find a way to make this the dominant narrative about our response to COVID-19. You all are doing amazing work within local communities. I believe it was Ms. Esparza that said, health is local. I would say indeed it is, and I would say health is primary and all else is derivative. And this particular moment in time is helping us to understand that. So it's been my pleasure and honor, and I hope you all have enjoyed engaging in this wonderful experience together. Thank you.